First of all, I'd like to introduce, we have 5 new employees. We'd like to get these folks introduced. Samajay Cole, he is about to be testing for his paramedic. Garrett Lord, about to be testing for his paramedic. James Lovelace, about to be testing for his paramedic. Brandon Mazel, I get it right? All right, paramedic's been paramedic a couple of years. Yay. And so moving here. And then Miss Elizabeth Anderson, and she'll be starting her advanced class. So guys, if you see these folks out on rotation, welcome them, and they'll be coming along with us. Now, they have to go, they have a meeting, what time? 1:30, so we got a few minutes with them, but they'll be getting up and leaving in between. So they have a meeting downstairs they have to go to. First of all, we're going to continue with our feedback processes that we've been having. It was a 54-year-old male found in actually cardiac arrest. They got Rosk at about 23 minutes, transported him to the hospital. Once they got to the hospital, they took him to the cath lab. As you can see, he's got a pretty large blockage right here in his RCA, and so pretty big inferior MI. They did a very good job with this, managed him very well. He did pass away at about 5 days, but it gave the family some time to spend with him. So great job to Amanda Miller and Dalton Wren. Next, we had a 78-year-old male with sharp chest pain radiating that was radiating chest pain up to the left shoulder. Sudden occurrence about 15 or 20 minutes ago while watching television. As you can see, he's got a very large blockage right there. They called it about 70%. You do see a little bit of flow there. Once again, they achieved the 12 lead in about 6 minutes and caught this very soon. Great job, Chris Mayo and Alyssa Tillman. Next, we had a 57-year-old male with an upper abdominal pain and shortness of breath. That's all that came in. They did a very good job getting a 12 lead on him. No really other complaints. He was diagnosed with pneumonia the week before, was on antibiotics. Is that a general call for us every day? Absolutely so. The team did a good job getting a 12 lead within 7 minutes. As you can see, he had a very large inferior MI, actually had 2 blockages there, and was able to get those corrected. Pretty nasty 12 lead right there, big tombstones, and great job. Brian Barker and John White did a good job. 53-year-old male with mid-sternal chest pain was radiating as well, stated that he felt a block in his chest. That's the only thing he said, no current past medical history. They had a 12 lead in 4 minutes. Great job, Kelly Barrera and Michaela Salinas. As you can see, right there, a very large blockage there, and another one in his, this is a high LAD coming off the left, so very, very high. This is your Widowmaker right here, and they did a great job getting them there, and as you can see, a pretty significant 12 lead. So everybody, all those folks I did not get any of the neuros accomplished this time for intervention, but we had several last month getting them to the cath lab suite quickly in for thrombectomy intervention in the brain. So they did a great job. We'll try to work on those for next month. We just want to try to provide everybody follow-up as much as we can with our STEMIs and with our with our LVOs, our large vessel occlusions. We want to make sure that everybody's getting a good feedback from that so they understand those processes. We're going to talk to the oddities today about cardiac arrest, especially focusing on pediatric or young adult arrest. We have had a slew of very young, under the age of 35 cardiac arrest, and a lot of those being below 25. So we want to talk about not just the average everyday things that we think about, like trauma and hypoxia. We want to move into some of the things that we've seen causing these arrests as of late. You know, one of the things we think about, early 80s, late 80s, this is when they really started to perfect pediatric cardiac surgery. So they were able to take these patients that normally weren't living with transverse vessels, and doing Norwood procedures and doing all these different things, trying to get these kids to stay alive. And now we're starting to see the repercussions of them 20 years later, because now they're becoming young adults, and we're seeing some of the etiology behind that today. So we want to discuss some of these things. So today we want to examine the zebras in the pediatric cardiac arrest. These are looks like a horse, but it's not. He's got the stripes. And so we need to start picking those things out of what's causing some of these unusual cardiac arrests that we have. Understand the significance of certain EKG patterns of what we're seeing with some of these and why it's causing that, and look at the unusual patient cases in the detail. And then we have a skills overview today of an orogastric tube. That's something that we don't do a lot of here, and it's probably something we should do more of with our intubated patients, especially with our pediatric population. So we'll visit about that. So adults are pretty easy. Typically everybody over the age of 35, you're talking about coronary artery disease. Some of this may be genetic coronary artery disease. Some of this may be they're just predisposed to it, and they eat bad, and they don't live a good lifestyle. They smoke, they drink, and that's causing high mortality with a lot of these folks. Blockage narrows. This is when blockage is narrowing the coronary artery by greater than 75%, and then they develop a clot or a booger in there, and they occlude that the rest of the way off. They have to go in there and open that up, whether it be from the blockage. It could be 100% blockage, but it could be also with the clot that's building up inside of there as well. Children don't have all of these years of eating those nasty cheeseburgers that we all eat. They don't have all these years of building up these cholesterols and these the triglycerides and all this, the bad stuff that starts to plug our arteries. And besides the outsource of trauma and hypoxia, those are our main causes of pediatric cardiac arrest. We all know that. We all know that if our kids, the number one cause of cardiac arrest in a child is typically respiratory arrest. And we've got to be aggressive with those folks. Then we also talk about the trauma. You know, trauma is the second leading cause of death in children. And so we want to make sure that we're taking care of those pediatric trauma patients. But uncommonly, there's a lot of mechanisms that begin to occur with care that affects us outside the hospital. Now, no, we're not going to cover all of these, so don't start freaking out that you're going to be here for 3 hours. But some of the things we do want to talk about today is a hypertrophic cardiomyopathy. So we have that enlarged left-sided heart, similar to our congestive failure patients. You know, some of the things that we don't think about, but myocarditis. You know, you'll get patients that may have a tooth infection for a long period of time, and sometimes that bacteria it travels, and it usually goes two places in kiddos. It either goes to their brain or their heart, and it can set up as an infection at that point, which can cause some secondary issues. Mitral valve prolapse, murmurs. We see these things over time with kids, and left ventricle obstructed outflow obstruction, tract obstruction. These are a lot of problems. On the electrical side, we start thinking about prolonged QT intervals. We start thinking about stuff like Wolff-Parkinson's White, Brugada syndrome, and complete heart blocks. So we start to see these things, and then we have our average. If I have a 17-year-old kid who's apneic, what's the number one thing we think of as paramedics? A drug overdose. And so those are still those things that we have to consider at the end of the day on taking care of these people. The problem with it is the statistics are very limited with our pediatric population. There's not a CARES program for pediatric world, so we have a hard time tracking causes of arrest and what is the survivability of those pediatric arrests. So it's not like we have some lay person sudden cardiac arrest registries that are out there that we can look at, but it's really limited with what we have. In 2005, the Center for Disease Control talked about 2,000 patients who were under the age of 25 that were involved in a cardiac arrest, and that was excluding the SIDS cases. Okay, so we know that our SIDS cases, they're a whole nother monster in themselves. We have a large number of those, typically within a year. But the sudden cardiac arrest is rare in the kids, and so we've got to start figuring out what is the zebra among the horses? What are the outliers that we're picking up here? Before 1990, ventricular fibrillation in children was considered an anomaly. It was considered something that didn't happen really, because every time we found kids in cardiac arrest, they were always in asystole, and we weren't picking up on that VFib in those children. But the fact is that resuscitation efforts were directed toward oxygenation and ventilation with those kiddos because they weren't really ever found once again in the VFib. We always thought it was just a totally respiratory problem. The outcomes were usually never very good. Some regarded attempts at pediatric cardiac arrest as being futile, why are you even doing this? And we've all known, we've worked pediatric codes that we knew we probably shouldn't have, but we did it for family purposes and we transported. I think everybody in the room has been doing this any time, has done that. And you've known the outcome before you even started, but you had to give it that chance. But then VFib virtually was unheard of once again in the children up into the 90s. And why was that? Is because we didn't have AEDs available. It was probably some of the fact of they were in VFib for a short period of time early and then got into asystole very quick. They didn't have that threshold of holding oxygen or being able to stay in VFib for a long period of time like we see in our adult patients. In 1995, two important things happened though. AEDs were distributed and were becoming widespread. And contraindications prior to release, the studies were published that 19% of resuscitation efforts for sudden cardiac arrest, these patients were in VFib from age 5 to 18. So that gave us a whole new look on what we were able to do for these kids, because all of us know if we have that patient in VFib VTAC, I have that highest chance of survivability in those patients, and that's why that stuff is measured. Of those in VF that were found in the 1995s, was 17% of those were discharged with good neurological outcomes. That number is astronomically high because if you look at our VFib outcomes right now on adult patients across the United States, they're 6 to 8%. So they're just not there. And so you can see, and that's compared to only 2% with our asystole patients. So for the first time, we're starting to actually see these kiddos in VFib. Some of the problem is they determined in 1996, though, is a lot of the EMTs or below, like an ECA, just a first responder that may be responding, didn't know how to use an AED. And so that was part of that problem, was starting with that education process with determining how these kids, you can put these kids on an AED and you can start to determine what their rhythms are early on. Remember that once again, hypoxia and trauma is the trauma-based hypovolemia is the #1 cause of cardiac arrest in those kids. We understand that. But some of the three things that we really want to look at today is the hypertrophic cardiomyopathy, the Brugada syndrome, and the prolonged QT syndrome. We're going to take an in-depth look at all of these. So let's start off with the most common zebra of all of them. The most common cause of pediatric cardiac arrest that's outside of our trauma and our hypoxia is a hypertrophic cardiomyopathy. This is where we get that enlargement in the left-sided heart, similar to the congestive failure patient. And we think, man, we really don't, or we get there on scene and they say, yeah, they've got a hypertrophic left heart, they've got a murmur, they've got these things, and you just kind of chalk it up to, well, they've made it this far, so we're probably okay. And sometimes it's just a matter of we're not understanding that whole etiology of what's going on. 1 out of every 500 kids ends up developing this across the United States. So how many kids are in Lubbock alone? I couldn't tell you the number, but if you got 1 in every 500 of them, we've got a pretty good little slew of them there. This is a genetic disorder that gradually thickens the wall from no etiology. You know, our congestive failure patients, they have an etiology behind why their left ventricles are getting thick. A lot of times it's pulmonary hypertension or it's vascular hypertension systematically. You know, you start looking at infections can cause it. You've got a lot of different terms, but these kids don't have that. They have a genetic problem that has caused their cardiomyopathy. Once again, this is very similar to our congestive failure patients, but you don't have the outlying flow of fluid problems and other issues, potassium retention that they may have. Most of these patients are asymptomatic. That's a good thing for us. But some of the symptoms is you know, we go in on a kid who's, you know, in a football game and he says, man, I'm experiencing chest pain. Well, if I was playing football, Chad would probably experience that same chest pain. But this is a healthy 17-year-old kid who works out all the time, and we start to think, you know, you're having chest pain. Okay, so what? Are you sick? You've got a little infection? What's going on? Exertional dyspnea. This is where, you know, yes, during a football game, they're going to be breathing hard, but this is that external, that dyspnea that they're really starting to have a lot of problems, and they're starting to shut down respiratory-wise. Syncope or near syncope. How many times have you ever said, you know, they said, well, oh yeah, he was out. When I got here, he was unconscious completely. And you think about it, and you think about these etiologies, these processes, as we go along and we go, okay, they passed out, you know, they're awake now. Did they really pass out? Does this layperson really know what that syncope looks like? That's a serious problem with our kids with a hypertrophic left heart. Dizziness and even sometimes, once again, sudden cardiac arrest. Now, we had an experience at 2 years in a row at 2 football games of kids in sudden cardiac arrest. And so this is definitely something that is prominent in the community. And remember, 1 in every 500 will have just this form of a genetic problem. From the pre-hospital side, sudden cardiac arrest in sports that are related to the hypertrophic left hearts, 48% of them are cardiac. That is the cause of 48% of our sudden cardiac arrest that are under the age of 35. So these athletes, and once again, now we've added on top of that our congenital heart kids, our congenital children that they fixed early in life. Now they're starting to get old enough, and we're starting to see these problems consistent as they go through. They don't tolerate heat real well. They don't tolerate the extreme colds real well. And so this is something, and when are they the highest in activity? Typically is in the summer. And so you can see as they're out and they're doing those things, they're chasing the squirrels, they're going along with this process, this is where they become heat-related problems. Patient education for presenting these syndromes. Once again, the high and low temperatures, this is a big problem with them to prevent their overexertion of themselves. Once again, activities like football or sprinting, stuff where they're moving very fast, very quick, and then they shut down. These kids need something more like swimming or long-term sports. I think she put, pitching rings, bicycle on level terrain. Those are safe things, but kids with this hypertrophic left heart don't tolerate that exertion very quickly and the need for that. Structurally, the myocardium is hypertrophic. Once again, remember what that happens is we have our Stirling effect, our Starr's law, where we're not able to feel our left ventricle. That left ventricle is a lot smaller. I'm not able to get all of my blood flow in, my pump from my atrial, and so I lose that portion where I'm able to contract and to get my flow. My coronaries are the first thing to suffer, which can be a cause of the sudden cardiac arrest. Let's look at Brugada syndrome. So years ago in Asian countries, boys were known to wear girls' clothes to bed at night. And they did this because they thought it was evil spirits that were killing the boys off quicker than they were killing the girls off at young ages. But it's what they found out is that it had nothing to do with the boy wearing the girl's clothes or just a boy at night. It was trying to trick the evil spirits, is what it was Brugada syndrome. And this was 10 times, the male was 10 times more likely to have sudden cardiac arrest and suffer death for young kids. In Asian countries, the Asian population, 7 to 27 per 10,000 individuals. In Caucasian, it only happening 1 to 7 per 10,000. So this presents as an arrhythmic problem and sudden cardiac arrest with our ventricular rhythm. Brugada syndrome can be increased by fever. You know, they have a lot of infections in young kids. High fevers, increased vagal tone while sleeping, and or alcohol intoxication. Is what they're relating this to, though, is the elevated testosterone levels have a risk for all of these things with increased fever, increased vagal tone at night while sleeping. The syndrome is considered a channel myopathy. So guys, this is where we really start to think about what all is going on. Our sodium, our calcium, and our potassium channels. This is where this syndrome kicks into place, and these cells don't have normal transverse where your potassium leaves your cell, your calcium leaves, your sodium leaves, and that's what causes our contractions in our heart. It's not a structural issue with this. It's actually a channel issue with them, with the potassium, sodium, and calcium. Most of these patients, once again, they're very hard to diagnose because you can do a 12 lead on them. It's going to be a fairly normal 12 lead. You're not going to think anything. They're going to say, you know, I'm having chest pain. I was having chest pain at night. I've got this, that, and the other. And, you know, this is a lot of times, though, with 12 leads, you'll see that they will have, just in V1 and V2, they can have what they call a Brugada's pattern. And this is where you have the negative T wave follows the cove. And so you've just got almost look like an ST segment. Your J wave's elevated there. And so it makes it look like it's almost ST segments in V1 and V2. Just because they have this doesn't make this that it's Brugada syndrome. There's a lot of things that lead up to this. But some of the findings with this is we need to make sure that we're doing a good 12 lead. We have good placement of our 12 leads, especially on kids. 12 lead is something that we don't do regularly on children, so it's very hard to get good placement on those kiddos. Some of the other things that can cause these EKG changes, though, is electrolyte imbalances, right ventricle enlargement. So not only our left side that we just talked about, but now we have right-sided enlargement, and they can also cause some of these ECG problems. Beta blockers, calcium channel blockers, that makes sense with Brugada syndrome. Stuff like antidepressants, alcohol, and cocaine can definitely affect this syndrome as well. So what makes Brugada syndrome? Well, first of all, in addition to having the Brugada's pattern on a 12 lead, they also need to have one of the following. They survive a cardiac arrest event, they witness or recorded of polymorphic ventricular rate or ventricular rhythm, a history of non-vagal syncope, and cardiac arrest of a member of the family that's greater or that's younger than the age of 45. We see that a lot. You know, they'll say, do you have any cardiac history? No, but my dad died at 42. And you're thinking right there, well, that's a genetic issue. Could it be this? It definitely could. Or it could be any other coronary artery problems. Like other zebras, though, this hospital diagnosis, once again, is very difficult. You know, we need echoes. We need lab values to help us determine these things. 10 to 30% cardiac arrest in adults with this syndrome, and it is increasing still with the male generation, or the male gender. So that is an increased risk of the Brugada syndrome.
I wouldn't say only, that's a big risk. Does anybody in here want to walk around knowing they got a 10 to 30% chance of arrest?
Yeah, especially the guys. The ECG pattern can be invoked in the hospital with injecting class 1 antiarrhythmic medications, so they can regenerate some of this, and that's how they start to diagnose the Brugada syndrome. This is something, have you seen this? You saw?
I've personally found it one time as a resident.
So,
it's rare.
Yeah, it's very, very rare, but it's definitely a problem. We've almost seen the case here in Lubbock, and that's why we wanted to visit about it. Let's talk about prolonged QT. This is a genetic disorder. The thing is with long QT syndrome, this is one of these things that they're very high risk of ventricular tachycardia, torsades, VFib, VTAC, and so we've got to think about this will lead to cardiac arrest, lead to syncope, and sudden death of these patients. And it can also be acquired in a non-genetic basis. This is one of these things, certain medications, as we talked about, can cause a long QT. Electrolyte imbalance, severe strokes can cause this, and some acute myocardial infarct. So it's not just a genetic issue with these folks. So the QT interval presents with a period of depolarization and repolarization between your Q waves, and so I have a lengthy time where my repolarization of my T wave is not occurring like I need it to, and this process is where we start to widen that QT out, and so we're in between those two Q waves, and that pattern begins to widen. This is the slowing activity of the calcium and the sodium, and then we have the ROT phenomenon. That's why, what else do we do on a regular basis to prevent an ROT? Anybody guess? Synchronized cardioversion. Okay, that's why we do that, is so it's synchronized and we're not creating an ROT phenomenon. This will definitely move them into a ventricular rhythm if we're able to hit that. The huge T waves, once again, can be associated with the prolonged QT intervals. As you look at this, you're thinking immediately this is just a big STEMI. And you're right, you do have large ST segments. They are not able to repolarize at that point, and this is definitely becomes a problem for us because of that. So what is prolonged QT? But as you can see, you have very long. So a lot of this is caused by a rate issue. A lot of this, we look at this and say, well, it's just bradycardia. That's what the problem is here. Anything with hypokalemia or hypokalemia, this is definitely becoming a problem with these folks. Now, are we going to know about the low potassium or low calcium in the field? Probably not. There is a chance they could say, hey, I just had labs drawn, or the hospital called and said I need to come in.
Does Old Monitor give the QT measurement?
It does.
That's actually pretty
reliable. I would venture to say that probably not a lot of people read it. Right. Is that fair to say?
is that over 500, then look closer.
460 is actually the number, but 500's just a good, easy number to remember. So this can occur in 1 out of every 2,000 to about 1 in every 5,000 people. So as you can see, this is rare, but this can be a #1 cause of torsades in our patients. And it may self-terminate as torsades at that point, with about 4 to 5% of these being fatal. And so this is definitely can be an issue for us. So typically, what are we going to do for these people? We're going to follow our protocols. VFib, VTAC, whatever they're in, we're going to work through it. But the literature shows that lidocaine on these patients may be a better antiarrhythmic than amiodarone, because amiodarone, I start to block my potassium and my calcium beta. And what's our #1 cause of this? Can be from hypokalemia and hypocalcemia. So definitely can be a problem for that.
You know, Brugada long QT and hypertrophic is something that's pretty rare. Has anybody seen any of these? Nobody? You probably have, just didn't realize it. I think one of the most helpful things in the ER, and now that we've kind of brought this up and some of you will go read about it some more, not everybody you see are going to be, I think they may have Brugada. You know, that's just kind of how things work. But what I appreciate in the ER is for somebody to come in and say, hey, you know, just maybe this guy's got Brugada. Because we try to think about it on every patient, but it's hard to, because these are items over the course of a typical emergency physician's career they may see 2 or 3 times. So they're very rare, but as we talked about, these are young people that die from these. And yet if we find them and do something about it, they live a normal life. So it's a really rare thing, but there's a really big reward if we can find it and do something about it. And just, you know, syncope, everybody in here has run on multiple young people that's passed out, right? I mean, half the people in the room is probably passed out, not from drinking, but just, you know, passed out at a vagal episode. But that's often how these patients will present, is they just have a syncopal episode. They're 22 years old. You're like, well, you were up too late studying or whatever, and maybe you don't need to go to the hospital. But remember, they could have one of these underlying issues as to what brought on that event. I already kind of mentioned, and we touched on, these are all extremely fixable, very survivable. It's just trying to find them before a bad event actually occurs.
What is the do something about it? What do they do for them long term to fix some of that?
So sometimes as simple as like a long-term beta blocker, more invasive, sometimes like an ICD. Those are usually the 2 common treatments for, I think, about all these. We talked about one of the big concerns of the deterioration, the VTAC, VFib, torsades. So if they have an ICD, they can get popped out of that. And then a beta blocker can be protective, cardioprotective to prevent that. So especially like the hypertrophic, I've seen people that have that diagnosis, and, you know, they'll be 24 on a beta blocker to try to prevent that and try to slow the heart down. So, you know, ICD, you know, obviously taking a beta blocker is not a big deal if you're 27 and you could die by not taking it. Same thing with an ICD. Yeah, it's an implanted device, but it's life-saving. Any questions? Cool.
Okay. So we had a 911 call on an 80 kilogram patient in his late teens who was at the golf course, had a sudden, got up to tee off, swung, and supposedly, quote unquote, passed out. Bystanders initiated CPR. They found out that he was not breathing, nor had a pulse, and they started compressions. As you can see, dispatch time 12:07. Arrived on scene and with patient at 13, so very good, very quick times, and he's getting compressions the whole time. Patient was found unresponsive once again at the golf club where he had swung, became unresponsive, and once again they started compression, unknown history, unknown allergies, and unknown meds. The patient was found apneic and appeared very pale in color. CPR was once again started. As you can see, they did a very, very nice job documenting their cardiac arrest. And so they did a nice job talking about those processes, which helps defend you long-term with your documentation. Passive airway, cardiac monitor in place. They started in, got an IV pretty much immediately, began with epi, and went ahead, and then first vital sign, of course, nothing, and he was in VFib. They went ahead and tried. You got a teen, sudden cardiac arrest. What are most of us thinking? You've been out on the golf course. Did you get into something? It's always one of the things we need to consider with those people. They went in and followed with some Narcan, no change. Once again, initial rhythm was VFib at 120 joules, defibrillated him. Intubated him, started epi once again, went to amiodarone, defibrillation again at 150. Still no change. They defibrillated 2 times with no change in his rhythm. Once again, end titles are showing 11. What are we thinking at this point? This is young, low end titles. This is not looking very good, is it? And so we're thinking, yeah, he's in VFib, but we have a very, very low end title, not looking real well. Once again, there's your underlying, the see-through, so we're able to see that. Epi, defibrillation again at 200 joules, amiodarone. Then they noticed the patient started to tear. And guys, we're seeing more and more and more of this. Patients moaning during defibrillation, patients tearing during defibrillation or during compressions. And that's because your CPR is so good, you're providing that cerebral perfusion and keeping them neuro intact more by providing blood flow. They did a good job. They chose fentanyl there to do a little bit of pain management while they were doing in the middle of the code and doing compressions.
And also, this has been talked about in EMS circles because we're seeing such good CPR being given. And, certainly on one hand, you're saying, well, this person's in arrest. We really need to be giving fentanyl or ketamine or something. But I think generally the answer to that is as long as it's not distracting from the CPR. We absolutely should not distract from giving good CPR to give a dose of fentanyl or ketamine or something.
So they continue with the epi, then they move to double sequential defibrillation. So they remember when we put our AED on, we want to push the 2 buttons on the side, move it into manual mode, and that helps get this over to where we can control that and do the synchronized cardioversion. Synchronized double sequential. So they got him at 200 joules on one, 120 on the other, so you're at 320 biphasic joules at that point. They had a brief moment of ROSC right after that. After 30 to 60 seconds, the patient came out of cardiac arrest and then went back in. Again, they began CPR immediately, went ahead with sodium bicarbonate at this point. At this point, they're about 29 minutes into this cardiac arrest. Again, large spike in CO2. We're thinking things may looking better. We have ROSC again with a decent blood pressure, 106/67, heart rate 123. Pulses are lost again. CPR is once again started, and the crew continued CPR, never gave up on him.
What's the kid going into every time they lose him?
VFib. So he stayed in fib, persistent VFib the whole time.
Did they ever give lidocaine?
No, they didn't. So he presented to the emergency room, gave amiodarone bicarbonate. I'm sorry, there toward the end he was going into a PEA rhythm. It was a nasty looking PEA. I mean, it didn't look, wasn't real organized. That was what he was after the double sequential. Sorry about that. He went into PEA. Had to think about it a minute. He got all those. So 9 minutes of CPR was performed. Once again, they lost pulses on transport. Began CPR again. Got to the ED. Got pulses back again. And here's what they found. His initial pH, 7.051. Not good. And his potassium and his calcium extremely dangerously low, 2.6 and 1.10. So very, very, very low. Just a kid out playing golf for the day. And so you got to start adding those up. Remember, that's what we're really thinking with Brugada syndrome. We're starting to think about those processes. And so this is where family and friends reported that he had just had a cough the last couple of days, so that really no complaints since he fell at the golf course. They went ahead to CT with no hemorrhages. He was started on post-arrest hypothermia for 48 hours. He remained chemically sedated and intubated. Family reported that the patient had a mild cardiac murmur, which I wonder what the percentage of people that a lot of people have murmurs, and so that's something we don't think about a lot, and no additional diagnosis or medication. Hypokalemia and hypocalcemia was treated over the next 2 days and corrected. After weaning off of hypothermia, He began in a persistent prolonged QT interval, which was about 540 milliseconds on a 12 lead, and he had no signs of Brugada syndrome in V1 and V2. He was extubated with no neurological deficits, did very well, denied drinking any energy drinks that may trigger certain things, as we've talked about before. The prolonged QT syndrome was considered in this patient and may be the underlying cause of that. He did agree to a bi-chamber, a dual chamber ICD to where he got that device in place, and he was discharged 7 days later to his family in outpatient rehab. His home medications now include beta blocker. So as you can see, they were trying to figure out which way to go with this. The crew did an absolutely awesome job.
He fed, what, 4 or 5 times, went to the double sequential. Is there anybody that doesn't believe double sequential potentially could save some lives? Certainly makes you wonder about this guy, right? We got no changes till we hit that double. And then I guess we got rocked a little bit, we deteriorated kind of back and forth, but we got something. Because of persistent V-fib, we just weren't getting anywhere with that. I don't know much more else to say about that. I mean, this was solid. This is why we do what we do. And this guy's back out on the golf course. He's got his ICD and beta blocker now, and theoretically won't code again, hopefully, on us at such a young age. So, you know, you think back, if we had done crappy CPR, maybe if we hadn't done dual sequential, this guy would have been dead, right? Good chance. So, you guys are awesome. Thanks.
Two quick questions.
Yeah.
The pain management when we're doing CPR and they're showing signs, I know it won't for VFib, but if they're in a PEA rhythm, would ketamine be a better choice to hopefully maybe drive a little blood pressure and start feeling a pulse?
I would tend to think that, I think ketamine's probably the better choice, period. Either way. You know, it shows more chance of being more cardio supportive, I guess you could say. You know, fentanyl doesn't really show that much negative. I tend to just like ketamine. I think ketamine's probably a better choice, but I think fentanyl's appropriate. I can't prove that one's better than the other though. You know, trying to use something like morphine or something I think is a bad idea.
Something else we've seen in the past is people moving during cardiac arrest, so they've elected to paralyze them. And we've even seen some succinylcholine used. What would have happened if we would have used sucks on this guy?
You know, paralyzing somebody what does it do for pain?
Nothing.
Nothing, right? It just makes it where now I can't move arms or I can't try to fight you. So,
And that's why we've opened that sedation protocol a little bit more with the ketamine. My opinion is ketamine is better at that point because you do get some drive of the cardiac. You do get some drive of pressure if they had it. So that's kind of my thought. All right, but they did a great job managing this guy. And you know, you think about it, in titles of 11, you know, we're trained to think, well, you're in a metabolic state, but they didn't give up. They kept going. That was a good thought process on their part. Any other questions? All right, so don't get overwhelmed with our zebras. Manage our cardiac arrests like we manage them. You know, this crew probably had no idea on a prolonged QT. There was no way to know it. Brugada syndrome wasn't showing up anything. Even if it did, would they have caught it? Probably not. That's something, once again, very hard, very rare to see.
Crazy, this guy at what, 12 or something had an echo and evidently a big cardiac workup and probably didn't show the QT then. Or, you know, you get into these questions, like we mentioned, what, 460, and I kind of brought 500, but you know, if it was 465, was that significant? There's kind of that gray area there. Should you do something about it or should you kind of wait and see? But unfortunately, this can be the wait and see sometimes.
So this is what the wait and saw. So we think about our children with chest pain, with dyspnea, with syncope. You know, we always think, oh, they're just having anxiety, they may be faking it. You know, it could be something real. We really need to do we owe it to our patients to do that thorough workup and make sure that we're covering our bases with them. Once again, hypoxia and trauma are the first related cause of pediatric cardiac arrest, but there are other things that can take place. We're going to watch this real quick. This is Hank Gathers, who plays basketball, and he ended up having a hypertrophic cardiomyopathy. So guys, we think about who are the guys that are screen your athlete? Those guys have done a great job. They have picked up several cardiogenic problems with patients. Just doing general screenings is something that we didn't do for a long time. So let's watch him real quick. You think he's having a seizure right here. It's probably what most people thought. See how he remains stiff? What's going on? VFib seizure. So a lot of people may have never seen this before. It's something we don't see a lot in the back of our trucks, because the chances of somebody going to rest witnessed in front of you, this is the VFib seizure right here. They did no compressions till he got up, they pulled him off the court. And so I don't know what the final outcome on this one was, G.
Yeah.
Okay. So he did not make it from this. And that's so we just wanted to show that as some of the younger medics may have not ever seen a VFib seizure. I didn't see one for many years in my career. And so it's one of those things that you're thinking he's just seizing, but it could be a lot more than that. So we need to really pay attention, check those pulses with that. All right, so let's talk about the orogastric tube real quick, just as the skills proficiency. When do we need to be using our orogastric tubes? Is anytime anybody's intubated. You know, people think, oh, they have a GI bleed. No, that's not a good time. There could be a lot of different issues. They need one eventually. We'll let them do that at the hospital. Any patient that's intubated technically needs to have their tummy emptied. So they need an orogastric tube. We get it. It's busy in the back of the truck. Sometimes this is a privilege that you do for the nurses to help them out, but we don't think about our pediatric population. Our pediatric population gets air in their gut, they do not ventilate well. And so our PD population really need to have orogastric tubes placed post-intubation once cardiac arrest if we retain ROSC. That tummy needs to be deflated so the diaphragm can move up and down. Doesn't take a lot of air in a baby's tummy to cause a lot of problems for us from a respiratory side. Abdominal distension, prolonged BVM use. We know that, or having a gut tube in for just 5 breaths in while you're trying to see if that tube's in place, that definitely caused that gastric distension. Some of the contraindications, now we're not always going to know these, but esophageal strictures, esophageal varices, that's a huge big one we don't want to tank with, can cause definitely a lot of problem. Or caustic substances in the stomach. That can definitely cause us a great big problem because we don't know what it did going down and destroyed. So why not the nasal route? Sometimes you can develop nasal bleeding. It can cause, there's a lot of complications with that. You've already got them sedated, just do it orally. There's a lot bigger hole to get it past instead of trying to flex it past the tube. Technically, when you're doing a nasal, they need to have kind of a sniffing position, and that's hard to do with an ET tube. It doesn't take a lot of movement, especially on our pediatric population. just a simple movement into the sniffing position can pop that tube right out. Now we have cuff tubes, and so that's a good thing, but it can still cause issues. It requires, once again, a smaller tube typically to go nasal than it does oral, so we can put a nice big size in, and I don't, even with head injury, I can still put an oral in, but I can't put a nasal in. Remember that this is one of our setups right here. You have the connector right here for your suction, then you have your flow valve, so where you can turn it off and on to the patient. We want to make sure that we're measuring good. Our Murphy holes, those are the ones, that's the end that goes in, and we want to make sure that we're measuring it from the corner of the mouth to the ear and then down. We want to make sure that we're getting a good measurement before we place that. The turn valve, the blue line there, this is the feed and suction port. This is typically where we're going to keep it so it can vent and then put it on suction if at all possible. Medication port is on that end. That's something that should not affect us at all. We should not be given any medications down an orogastric tube in the field. Attach your suction to that port right there, and then your ARV is your anti-reflux valve. That's what's going to stop anything from coming up past that point. There's different brands in the Salem sump. Once again, this is the setup that we use here, and so we just want to make sure that everybody's familiar. Levine style tubes, we don't want to use those. We don't carry them, so we don't. But in case you go into a hospital, a smaller facility or a doctor's office, they may by chance have something like that. Let's take our quiz and we'll get you guys out of here. The initial